Good evening, everybody, and welcome to this last USANA webinar before we go to conference in about 2 weeks' time. Thank you to SAPA for hosting us, and welcome and thank you to Dr. Krubin Naidoo, who's going to talk to us about a topic that not many of us are very familiar with, and that is ECMO in the newborn. I'm going to let Dr. Naidoo introduce our speaker.
Thanks, Gugu. Welcome, everyone. I'm Naidoo, a neonatologist in KZN. And as Gugu said, Krubin's going to be speaking about an exciting topic this evening, the topic of extracorporeal membrane oxygenation. And many of us are unfamiliar with this procedure. It's being increasingly utilized worldwide in patients with hypoxic respiratory failure and cardiac failure. And the number of patients recorded in the ALSO registry, this is the Extracorporeal Life Support Organization, is 40,000 newborns since 1972. The results from ECMO, I'm sure Krubin is going to tell us more about this in his talk, have been largely favorable, with almost a 65 to 70% survival rate, and slightly more marginal results with regards to morbidity. The main indications for ECMO in the newborn population are congenital diaphragmatic hernia, persistent pulmonary hypertension of the newborn, and it's even been used in CPR, where ECMO forms part of the procedure in the CPR process. However, the cost and implications for this procedure are high, and this is with regards to equipment and staff and the long-term complications with regards to morbidity and follow-up. In South Africa, we have 3 ECMO registered centers, and one of them is state-sponsored. So Dr. Krubin Naidoo is our expert speaker for this evening. I'm always very proud to introduce someone from my alma mater. Krubin completed his undergraduate and postgraduate training in pediatric cardiothoracic surgery at the University of the Witwatersrand. He then completed a pediatric cardiothoracic clinical fellowship in the Stollery Hospital in Alberta, Canada. And here he gained experience in cardiac transplantation and in ventricular assist device implantation. It was also here that he was exposed to a dedicated ECMO program and realized the deficiency of the ECMO services in Africa. Krubin has a wealth of experience in using ECMO in both the public and private sectors, and he has a special interest in the retrieval and mobile ECMO services in South Africa. So thank you, Krubin. Thanks for joining us this evening, and I'll hand over to you now.
Thank you very much, Nari, and thank you for the organizing committees for having me. I trust my audio is okay? Good.
Yes, we can hear.
Thank you. Okay, so we'll just get back into the topic I'm going to chat about is ECMO in the newborn. And let me just... obviously, the definition is an acronym, the exchange of oxygen and carbon dioxide with or without circulatory support using a pump and oxygenator as part of a circuit outside the body, part of the constellation of extracorporeal life support modalities. And ECMO has become quite well known now as an ancillary therapy in an ICU setting. So moving away from the definition, who do we consider for ECMO? Often ECMO is considered in a very negative light. And what we've seen over the years as the therapies become more accessible and more successful are the contraindications that have slowly dissipated. It can now be used in any patient with potentially reversible pulmonary or cardiac disease, as well as septic shock. Those patients are usually deteriorating on ongoing or maximal conventional therapies. I think when we at that point of treatment, with best intention, there's a significant amount of iatrogenic injury going on, and ECMO will allow you to cut back on that and offer protection against further injury. And those will be things like ventilator-associated injury, atelectatic trauma, oxygen toxicity, renal dysfunction, and cardiac dysfunction because of high doses of inotropes and vasoconstrictors. I'm sure you can think of quite a few more. And what we really focus on mainly is the absence of absolute contraindications as a reason for needing ECMO. There are really no hard and fast rules to who gets or who warrants ECMO. There are guidelines, and the guidelines are well established in big centers, but you'll find there are often subtle differences between the centers. I've just introduced some here for the group of respiratory patients, cardiac patients, and the one common number that's often quoted is the oxygenation index, and the calculation is on the slide, using the mean airway pressure and the inspired oxygen concentration over the partial pressure of oxygen. Different centers use it with different thresholds. And the number of 40 is often associated, particularly historically, with a expected mortality of over 80% if therapy using the current modalities is continued. Now, you'll find different places use different values, and the value of an oxygenation index over 40 also traditionally applies to conventional therapies. The group from Karolinska proposed that for every extra therapy that is added, you reduce the score by 10. So, for example, an OI of more than 40 with conventional ventilation, if you're using an oscillator, you should make it an oxygenation index of more than 30 as an indication to justify ECMO. If you're using an oscillator with nitric oxide, you should reduce the threshold to 20, and so on. So if you have a patient, as we often see, with an oscillator, nitric oxide, and receives surfactant, they suggest that you reduce the oxygenation index threshold as a guideline to initiate ECMO to about 20. Or even lower. So the different guidelines fly for different institutions, but again, they are very institution dependent. I'd like to take your attention to the third paragraph, absolute contraindication. Pretty much that's what people use to decide on whether or not to use ECMO or not. Obviously, those conditions are without question unlikely to justify using ECMO. Up to a few years ago, relative contraindications were absolute contraindication. So what we found was weight less than 2 kilograms and gestational age of less than 34 weeks was seen as an indicator of a likelihood or tendency to increase bleeding on ECMO. I'm sure you guys will agree that they've shown now that ventilation strategy and use of inotropes of certain doses has also something to play, a role to play in intracerebral hemorrhage in those patients. And if we can avoid that, the use of ECMO may be an alternative in those patients as well. Mechanical ventilation, I remember many years ago, if you were on a ventilator for more than 7 days, a lot of centers would not give you the option of ECMO. In fact, it was well known that if you wanted great results, you offered ECMO only to those patients who were ventilated for less than 7 days. However, now that's been extended out to about 14 days. Certainly, that's our practice. There is benefit of ECMO for patients ventilated between 7 and 14 days. Not as much benefit as patients who've been ventilated for less, but certainly of greater benefit than if you're not offered ECMO and you fulfill the criteria. And the reason for that is purely the iatrogenic injury that's caused, the trauma being on the ventilator with high pressures and high volumes for a prolonged period of time means that the chances of recovery is no longer dependent on the underlying condition that justify the ECMO, but more on the iatrogenic injury. Often patients, especially in neonatal settings, don't have arterial lines. You rely mostly on capillary blood. So what has been found is that there are some useful surrogates to use for the oxygenation index, and one of them is the oxygen saturation index, using the oxygen saturation of the pulse oximeter, particularly preductal. And there is quite a linear correlation between the oxygen saturation index and the oxygenation index itself to use, again, as a guideline to when ECMO could be considered, should that be an option in escalation of therapy. So basically, in summary, ECMO is a supportive therapy, and it's very useful to think of it as a bridge, as we'd like as we'd hoped. It'd be great if there was a bridge to recovery, but also it's a bridge to decision. If you're unsure about the path forward and there's not the luxury, you don't have the luxury of waiting, as a bridge to longer-term support, which can be longer-term support devices like ventricular assist devices, or even to transplant. Again, the common disease profiles that we may see are meconium aspiration syndrome, persistent pulmonary hypertension of the newborn, and the PFC. And of course, the larger group that's been growing more, congenital diaphragmatic hernia in patients with cardiac disease and sepsis. So the reason for the decline, and we've seen a steady decline, and as Dr. Naidoo has reiterated, the ECMO registry, the ELSO registry, has been running since the mid-1970s. And whereas the neonatal group was the largest group at one stage, it's now slowly slowing down. And the reason for that is because of the advent of surfactant, better ventilation strategy, high frequency oscillation, and nitric oxide. So that leaves us with a larger group of patients with more severe illnesses like congenital diaphragmatic hernia and cardiac disease being patients post-cardiac surgery, and patients with primary cardiac disease like myocarditis, cardiomyopathies, intractable arrhythmias, a much more severe disease profile compared to the cases of meconium aspiration and persistent fetal circulation. In fact, if you look at historical data, at one stage, the survival to hospital discharge of patients with meconium aspiration were over 90%, 95% in fact, and that was purely because it was a very favorable disease profile for ECMO. To elaborate more about on sepsis, the neonatal sepsis guidelines that were released, I think, about 5 years ago, show that in addition to the traditional guidelines for ECMO, because obviously the vast majority of patients we see in the older age group, when I say older, I mean young infants and pediatric patients, are viral pneumonias. And those patients represent a subset of sepsis, but they follow the traditional guidelines. Besides those, the so-called catecholamine-resistant shock or pressor-resistant hypertension has also been shown to be an indication for ECMO as a consideration for escalation. Again, there are no consensus on what the maximum level of inotropic support should be, how long it should take before you should throw in the towel, before you start having signs, well, when you have signs of septic shock, or how rapidly you reach your set parameters for escalating further. I couldn't help notice, but on the left side of that of those guidelines was a time frame of up to about 60 minutes, but I'm not sure who follows that timeline, because often people would like to wait after they introduced therapies, especially for sepsis, to see if there's going to be a response. On this guideline, it's almost as if it's an hour or two is what should be considered as the limit. And despite all of those things, we always have those patients who challenge our judgment. And whenever we look at, when ECMO is an option, we always wonder, is the patient sick enough to warrant escalating to ECMO? Because the reason ECMO is considered as a so-called last resort is because it's not without its consequences, as is any therapy, especially an invasive therapy. On the other hand, has my patient gone too far? And is it too late to consider ECMO? And I think the question we ask is, if ECMO is a consideration, is it not possible here in our institution? Can't we just do ECMO, like you pull in an oscillator and connect it instead of a conventional vent? So let's look at what we need to do ECMO. Basically, you need to set up a circuit. The beginning and the end of the circuit is basically the patient. There's an access limb, or the drainage part of the circuit, which is called the venous part, that drains to a pump. And the pump, we can see, let me just see if I can grab this pointer. So that would be the venous limb coming towards the pump. Almost all current models now are centrifugal pumps. The blood enters the top, spins there and exits out the bottom, and makes the short pathway towards the oxygenator. So the important thing about the oxygenator is that if it's not connected to an oxygen source, it really doesn't give much more oxygen than room air. So the little green tubing is very important to be connected to a viable oxygen source and connected to the correct port. A very easy thing to forget in the chaos that ensues when you're putting a patient on ECMO. And then from the oxygenator is the return limb, or the so-called arterial limb, which returns to the patient. Just from looking at the circuit, it's impossible to determine what mode of ECMO you have, and I'll explain this later. When I say mode, I mean just the conventional types of veno-arterial and veno-venous ECMO. Other parts of the circuit that we call the auxiliaries are more important in pediatric, infant, and particularly neonatal patients. The heat exchanger, especially in neonates and infants, vital in controlling temperature. There's a tremendous amount of insensible heat loss through the circuit, as you can imagine. The surface area that's exposed to the ambient environment is considerable the smaller and smaller the patient becomes. Obviously, there must be a gas source, and the gas blender is vital, and I'll show you the particulars about that. There are a variety of sensors. So these are all clip-on sensors, sensing pressures at different parts of the circuit. There is a venous sensor, there's a pre-oxygenator sensor, and a post-oxygenator sensor. The importance of these are really in troubleshooting. Probably the most important part of the circuit is the flow probe. Flow probe is this structure here, and that's on the return limb, and that'll tell you what the effect of your cannulas, your volume status, and your speed is, and what's ultimately returning to the patient. There are obviously lots of port access points in the circuit. Those will be there on the oxygenator, and through these we're allowed to do our blood gases to check the viability of the oxygenator and allow us to connect access points for dialysis or renal replacement therapy, which we almost always now do routinely, even in patients who are not in renal failure, as a means of better controlling the fluid status of the patient. Sorry, let me just... Okay. We look in more detail at the oxygenator. There are various designs. but basically almost all of them are made in a similar place, and just wound into different configurations. But a large surface area obviously is mandatory on the polymethylpentene product. There's gas that flows in and gas that flows out. What we find is, although it's called an oxygenator, it's a much better regulator of carbon dioxide and a much more efficient regulator of carbon dioxide than an oxygenator. Around the gas exchange surfaces flows water that's connected to the heat exchanger we saw earlier, and very important in maintaining normothermia or even inducing hypothermia with surprising accuracy. The pump, there are different configurations of pumps. We're looking here at the one we used on the Fresenius device or the Xenios machine. This is a centrifugal pump. There are two sizes for the smaller and then the larger patients. The base of the pump is a magnet, and it floats an impeller above it. So there is no contact between the part of the pump that actually spins and the magnet below it. At the top, you have the venous blood entering, and below is where the blood exits towards the oxygenator. It exerts a negative pressure at the top and then a positive pushing pressure at the bottom. I like to focus on these two because these two are often forgotten again. The heat exchanger of vital importance in neonates. It's a simple device, extremely heavy, and which is often why it may be left out, but of critical importance. This was a study done in ECMO transport, and it showed the drop in temperature that occurs in patients essentially with or without the heat exchanger and a heating blanket indoors and outdoors. So if we just look at the panel on the left, the drop in temperature from so-called normothermia to about 32 degrees in about 10 minutes without anything, and that's indoors, the rate of cooling can be greatly slowed down with just using the blanket. Outside, even worse, the drop in temperature is much more severe, almost down to 10 degrees in just under 10 minutes with complete exposure. And as you start layering the patient with the, if you may, with the heat exchanger and then the heating blanket, the rate of cooling is greatly slowed down, but nonetheless occurs. And this is still a big issue for us with transport, particularly for neonates. If we look at the picture on the right, so this is what I was referring to with the blenders, gas blenders. Most hospitals only have adult blenders, and we just find that the blenders they have, and it's not pediatric or neonatal focused, will not be ideal for the ECMO circuits. Unfortunately, it's often just temporary until we can get them back to our facilities. But if you look at the high flow, it goes in gradations of a liter up to about 10 liters. If you're looking at running gas flows of 200 moles or 300 or 400 moles, as you often may have to do in neonatal patients, it's very easy to see how you can make those mistakes using a high flow blender. So much so that I've even seen these accidentally switched off trying to get to sub 200 or 100 moles per minute, which then means your patient is effectively getting room air. So important, the high and low flow blenders and the heat exchangers. The cannulas are the last and probably the most important part of access to the patient. The cannulas, the cannulation strategy will determine the type of ECMO, whether it's veno-arterial or veno-venous. And there are really two types of cannulas in production. They're the single lumen cannulas and the dual lumen cannulas. The single lumen cannulas, depending on where they're placed, one will be for drainage, one will be for return, is designated arterial and venous, depending on which structure they enter. An arterial traditionally goes into either to an artery or is the return cannula. They come in different sizes and different lengths. The The dual lumen cannulas, and I'll show you a picture a bit later, are actually more single cannulas that do the drainage and the return of blood. The most important determinant of your actual flow is the cannulas, and we'll discuss that a bit later. Finally, all those things are put together, packaged onto a nice console, and connected to a monitor, giving us all these readings. On the Xenios machine, the largest number is the flow, and the reason for that is because it's the most important. The only thing that you really can adjust here is the speed, and that's with the control over here. The rest are all a result of your speed of your pump, your volume status of your patient, position often of your patient, sometimes and the cannulation strategy. So we'll discuss some of those things later on a more practical basis. So I think it's important. People often talk about respiratory support. You just need VV, ECMO, and for cardiac or so-called circulatory support, you go more towards VA. And I think that's true in a sense, but it has lots of limitations because a lot of the time it depends on where you are and what you have. And when you start doing ECMO for smaller and smaller patients, you find that there are lots of challenges that you have to face with not just the infrastructure of the institution, but also the equipment. So traditionally, for respiratory support, yes, you use 2 single lumen or 2 lumen, 2 cannula veno-venous ECMO. Traditionally, the veins that are access to the femoral vein and the jugular vein. So you can drain out the femoral vein and return to the jugular, or vice versa. The important thing is that the cannulas should not be too close together. In adults, they talk about a distance of 7 centimeters, but obviously that doesn't apply to small and smaller kids. However, I'll show you in some examples. It's difficult to get them closer than that. And of course, then the 2 lumen, dual lumen cannulas, which can be used in any patient, really just go into the jugular vein. For more circulatory support, it does provide respiratory support. We use veno-arterial ECMO with 2 single cannulas. And I'm just going to talk about peripheral ECMO in the neck. For completeness sake, post-cardiac surgery, the cardiac bypass cannulas are simply connected to the ECMO circuit, making it central ECMO. But peripheral ECMO, the neck or femoral access are the 2 sites chosen. Obviously, the smaller patients, this is not really an option. So we limited to using neck cannulation with these structures here. Like I said, cannulas are very important. The predetermined amounts of flow is based on studies to determine the adequacy of tissue or basal metabolic rate at a tissue level. To achieve that, the correct cannulas have to be used to be able to achieve those flow rates. And there are lots of guidelines. They're available everywhere, including on the ELSO website. This is pretty much a physics phenomenon, but it's important to realize that the larger cannulas give you better flow. There's no question about it. If they're inserted correctly, in the correct position, and you connect it a certain way, literally there's nothing else to be concerned about except the volume status of the patient. If you do this wrong, it will be your bugbear for the entire run of the ECMO run. So we use, the other thing is it's important to have alternatives. It's important to have a selection of cannulas. It's important to have other means of accessing patients with different vascular access challenges. We've been in situations where patients we were putting on ECMO only to find out that they had a ligation of the internal jugular vein as a neonate, placement of a Hickman line, or thrombosis of a vein due to different previous central line insertion. We've pretty much seen it all. And I think the big thing is you often don't have a chance to retrace your step and go and rethink. You almost have to think of alternative strategies on the go or potential problems before you even do it, which becomes more and more challenging, especially if you start doing transport ECMO. Cannula positioning is vitally important, not just to prevent harm, but also to get the correct effect of your ECMO, and that ultimately is achieving the flow that you want to. We use a series of surface markings. Lots of imaging can be used as well, particularly as you'll see for dual lumen ECMO. And of course, once all of that is done, there's a certain degree of troubleshooting that you have to do. Ideally, you want to get it right the first time. However, during the initial run, or even sometimes a few days down the line, you may find you have to make adjustments, and there are ways of doing that. I just want to direct your attention to the picture in the middle here. You can see these cannulas radiologically, same cannula, and literally from the same manufacturer, will look different radiologically depending on where the wire is. But this cannula at the bottom may be in further than what shows up on an X-ray than the one above. And important to know, it's very important to know the radiological appearance of the ECMO cannulas that you choose to use. So let's look at the cannulation strategies. Pretty much, I think the gold standard for respiratory support is 2 cannula veno-venous ECMO, and choose pictures in adults. You can see here it's an access cannula in the femoral vein. That's the circuit, and a return into the jugular vein. And so that will be 2 cannula veno-venous ECMO. In the schematic here, you can see how possible it is, the closer that these two are, that you can suck out the venous return very easily, and the patient will not benefit from the oxygenated blood. There are easy ways of troubleshooting it. And the more and more your venous cannula looks like your arterial or your return cannula, the more likely you have to recirculation. The simple X-ray will tell you this, and it's very easy to distract the cannulas by pulling them further apart. To me, this ECMO gives by far the best flow because you have the largest potential venous cannula in, and your drainage is literally what determines your flow compared to the dual lumen cannula. In this picture here, you can see this would be a femoral drainage cannula introduced percutaneously. Those of you astutely looked at this X-ray on the right may say that there's actually no ECMO cannula on the right, and that's true. So this young lady came to us, and when we were actually in the process of cannulation, we're told that she had a procedure done which closed off this vein. So then we had to switch strategies, go over to the left side, and then use guide wires and screening to get a wire across from the left side, across the innominate vein and into the right atrial SVC junction to basically effectively commence ECMO on her. And you can vaguely see the drainage cannula over there, the femoral. The other strategy of dual lumen cannulation, can see the difference between this and 2 lumen cannulation. This is 1 cannula. We in the schematic, the larger out venous or drainage limb and the smaller return limb. The pressure in the return limb keeps this thing patent and stops it being squashed by the venous limb. There have been reports that, so this is where the SVC hole should be, the IVC hole, and then the return hole should be in the center, directed to the tricuspid valve. It's been shown that this is not a necessity. The hole can be anywhere in the right atrium, as long as these two further away. Surprisingly, not as much recirculation as you think. So the dual lumen cannulation strategy is a much more laborious, labor-intensive strategy, as you can see. So patient has to be positioned. You need screening. You need a C-arm. You need the right table. We use, of course, you need a radiographer available. Ultrasound, we use ultrasound now for all our ECMOs for finding, to do percutaneous access with micropuncture needles, and then a series of serial dilatations. you need to see this wire go down into the inferior vena cava, because if this wire takes a curve off into the heart, that's where all your future dilatations and as well as your cannula is going to end up. So it's important for this wire to go straight in, straight out. And often, if you've got a very prominent eustachian valve, it's going to stop this wire going down. So it takes a lot of patience. Sometimes you have to use a stiffer wire, and sometimes you have to do a few manipulation techniques to get this. If it doesn't work, then you have to resort to VA ECMO. So the importance of having other strategies and backup strategies is explained there. By far, our go-to strategy for most children, neonates particularly, and infants, is peripheral cervical ECMO. So veno-arterial, carotid artery, internal jugular vein. And the reason I've written 50 kilos there is because colleagues of mine have extended the use of veno-arterial ECMO up to about that weight in big institutions like Boston Children's, saying that the stroke rate of the smaller patients is equivalent to patients up to that age. So they will use this as the default if no other sites are available without hesitation. So we don't. We have respiratory ECMO. We most of the time will use veno-venous cannulation, unless they're very small infants and neonates. We will go veno-arterial, but it actually is quite comforting to know that the literature does support that you can do veno-arterial with cervical cannulation up to about that weight. What is quite striking, and I'll show you some imaging, is the sizes of the vessel. So the vessel over here is the artery, and the vessel here is the vein. And the reason the vein is that much bigger is because of the right-sided failure that almost all patients who get when they're at that level of support that they need ECMO. Venous congestion and obviously distension of the jugular vein makes this a very large comforting to find, but easy to damage, let's put it that way. Obviously, if patients have lines in there, you're trying to cannulate when this line is in the way. It's best to cannulate while the line is in situ. Obviously, place another central venous access like before that, but it's best not to pull out the line in anticipation of the cannulation. It's best to let the surgeons do it themselves when they're doing the cannulation, because it can be very messy with ongoing bleeding if a line has been removed an hour or two before cannulation. We secure our cannulas in the vessel to prevent or minimize the risk of damage. We are vessel fixers. They centers that fix and the centers that don't. We fix up to about 14 or 15 days of patients being on ECMO, and if the vessel is in good condition, we will try and repair both these structures. Obviously, for veno-arterial ECMO in the neck, as you can see, you're cannulating via the common carotid artery, going down towards the aortic arch. Therefore, we obviously cannot monitor oxygen saturations on that right hand, because they will reflect what the ECMO return cannula is, which will be very, very high. So this configuration here, you can see in a patient with a veno-arterial, so the venous limb over here, arterial limb over here, and I'll show you this young one of our neonates that we did in this patient here. As you can notice, it's got a different cannulation strategy. So this is the patient whose picture I'll show you later, and I showed earlier. This young lady is one of our smallest patients. We did about 2.5 kilograms. Very interestingly, was referred by her uncle, who phoned me in the middle of the night and said, my niece is in the neonatal ICU. They were told that they should prepare themselves. There's nothing else they can do. Don't you do something on the heart that can save her? And then obviously I took a walk and went to have a look at her, and she had some anomaly of an internal jugular vein. So we couldn't get the correct size venous cannula in. So we went for a cephalad cannula. So a cannula, although it goes in here, it's tunnel under and it drains the brain on that side. So we've got extra venous drainage, and obviously the head on a neonate is much better vascularized than an older patient, we were able to achieve our satisfactory ECMO flows and achieve our target. She came off after about 2 weeks of support. So this is what veno-arterial ECMO cervical cannulation would look like on an X-ray. Very important to know what your X-ray looks like, because within 24 hours, the X-ray is completely white and you have no idea where the cardiac silhouette is. The question obviously asked is neurological injury with common carotid artery occlusion for complete occlusion up to a few weeks. And I'm pretty much going to answer that question about neurological injury here, because I haven't covered it extensively. Almost all patients who get veno-arterial ECMO and cannulation of the carotid arteries and cardiac ECMO have some degree of neurological injury on close testing, and that's testing early on after ECMO withdrawal or later in life. There is some degree of neurological dysfunction that has been measured with some test at some point by someone. So what we hang our hat on is that there's supply, contralateral supply from an intact circle of Willis. I have a slide actually of all the variations in the anatomy of the circle of Willis found, and it's quite alarming to see that. But by and large, what has been shown is when the carotid artery on the one side is completely occluded, flow on the opposite side has been measured to go up to sometimes more than double on ultrasound testing of those patients, and pretty much we comfort ourselves with that fact and hope that we do not see severe stroke, ischemic stroke, as a result of carotid artery occlusion for the ECMO run. But essentially, this slide just sums up very nicely the management of a patient on ECMO, which is literally just a multidisciplinary task. And the way I look at it is the more eyes that are on the patient, the better the results. And we're very grateful to the dedication and astuteness of our intensive care staff, the nurses and the doctors, for picking up all the non-surgical things that we often will not see as surgeons. But basically, this is what our approach is. We aim for flow rates of up to about 200 moles per kilo, and we try and achieve this at cannulation, because if it gets to that point, we don't need that. We need it that high. We're able to achieve that, but often you need anything from 100 to 150 moles per kilo for a neonate, and if we can get to 200 at cannulation, then we know we have enough in reserve. Your targets are getting a lactate down to below 4, or even better, below 2, adequate urine output, although now with our more liberal use of CRRT, it's not that we're not that fanatical about that, especially patients who go on ECMO with the absence of pulse flow, and the use of CRRT, the urine output often drops below that. We aim for oxygenation levels of over 80 to 85%, or mixed venous saturation of about 70, hemoglobin of about 13 or 14, normal capnia, temperature control. Basically, we try and maintain normothermia because it also helps with hemostasis. The patients with hypothermia, particularly the neonates, are more prone to bleeding complications. And then we pretty much follow protocols around anticoagulation. Literally in adult and pediatric and neonatal literature, this is one of the big topics that's, no, I wouldn't say controversial, but just people approach it in despair because we still haven't found the ideal anticoagulant. We aim for target ACTs, or activated clotting times, of around 180 to 250 seconds. The ACT machine we use is a point of care machine. In the absence of that, activated partial thromboplastin time targets about 60 to 90 seconds, which is very dependent on the way this test is done. You literally have to get someone from the laboratory standing there while you pull the sample. They need to go as quickly as possible to the lab, run the test. It's obviously not going to give you an accurate result, and you hope they don't batch it, because then you're going to get an incorrect result. But often it's difficult to convince them to run that test as a lone test, whereas they usually just wait for batches of blood tubes to come in before they do it. You basically is correcting and replacing blood and blood components and electrolytes. The ECMO circuit, by nature of the centrifugal pump, is something that traumatizes red blood cells. Blood components like platelets come out to the circuit when they recognize non-self and coat the whole entire ECMO circuit from the inside. It is not uncommon to see platelets drop precipitously within the first 24 to 72 hours on ECMO, and then after that, it should stabilize. Any drop later than that should alert you to the presence of possibly thrombus in the circuit or fungal infection. We maintain most of our fluid balance with renal replacement therapy. And we are fortunate that our renal team prefers to dialyze patients on ECMO rather than not. Blood pressure control is, again, one of the most challenging things on ECMO. Hypertension is actually your enemy. Hypertension basically fights with the flow of the circuit, because that blood is ejected rather than allowing the pump to draw it out. Hypertension also may predispose your patients to bleeding, whether it's overt or covert bleeding, and especially if coupled with things like a very prolonged ACT or PTT and thrombocytopenia. Blood pressure, I call it the triangle of evil. If you have those three things together, almost certainly you're going to get bleeding somewhere on the patient. And obviously the bleeding we don't see is the worst kind. Pharmacokinetics and drug dosing is a topic on its own, and I'm not going to say much about it, except that obviously the volume of distribution on ECMO, the smaller the patients are, is tremendous. The blood volume can increase up to 3 times on a small child. There's drug interactions, because there's often polypharmacy. There's consumption of drugs by components in the circuits, particularly the oxygenators. What we find is lipophilic drugs have to be dosed at much, much higher levels. So what we see is the doses that we use conventionally in pediatrics might as well be largely ignored, and we give the doses according to the effect or toxicity measures, because it can be very labile and very dose dependent. And I'll show you some pictures. The longer patients on ECMO, the more resistant they become to all these drugs. We then employ rest ventilation, which basically is going back to conventional ventilation, and the ventilator then becomes a monitor for us. We give us fixed pressure throughout the ECMO run, and we look at the volumes of air moving from the beginning of the run to when the patient is hopefully recovering. Obviously, as the lungs become more compliant, less waterlogged and recover, larger volume of air will be noticed and monitored as shown by expired tidal volume. Besides looking at those parameters, the bulk of our efforts is spent in preventing and managing events on ECMO, and these events can be considerable. Literally for the patients, I'll just run through this through these pictures here. You just find a pointer. So over here we can see hemolysis, smaller return cannulas, large proportion of thrombus in the circuit, especially in the oxygenator, higher speeds, or promote hemolysis. Not a good thing, because you'll be transfusing more and more. Infection, obviously, bleeding at cannulation sites, and even non-cannulation sites, and cannulation of vascular access sites. This was, I use this picture, it's an adult patient that we had to go and re-explore for someone, because this patient just dripped blood from poor hemostasis at the time of cannulation. And certainly over here, you can see that Avalon dual lumen cannula, as I spoke to before, so where the guide wire wasn't followed, and the cannula went into the right ventricle, perforated the myocardium. And on this echo here, you can see the pericardial effusion, and the resultant tamponade that's needed to be drained to improve actually the ECMO flow and basically save the patient's life. Let's see if I can hold this. Yeah. Complications of the circuit. As ridiculous as it sounds, this is very easy to encounter this as these oxygen lines lie on the floor, and it's literally a stroke of luck that this was. There is a troubleshooting sequence you follow if you notice your oxygenator is not oxygenating well, but you can see this is an obvious, easy mistake to make. Clotting of the oxygenator, inevitable. I don't believe there's any oxygenator that doesn't clot. This is what they will do. They will clot. And this is what we've seen, rinsing out an oxygenator. There's also fibrin formation. This is a different kind of pump head. This is the levotronic centrimag. And you can see with a large amount of clot, a large clot, chronic clot burden or fibrin, this impeller still spins. I have my doubts whether this clot burden will be accommodated in the Fresenius machine that we use. I don't think so. Cavitation. So with excessive negative pressure, air can actually almost be formed, if you like, in the venous limb. This has to be prevented at all costs because this air will go towards the pump, and if it gets in between the magnet and the head, that pump will essentially not spin, and the flows will drop, and that has to be evacuated as an emergency. Accidental disconnections are obvious. This literally was disconnected for a second, and that's how much of blood fell onto the floor. We very seldomly now, this was at a stage when we were moving patients to operating room for decannulation. We don't do that at all now. We do decannulation at the bedside, just to minimize adjustments, not just in patient position, but also ventilation, etc. Over here, you can see the patient will get, can and often get effusions. It's in enlarged pneumothoraces depending on the underlying disease. This will affect the ECMO flow, like attention pneumothorax affects cardiac output. This was fixed, obviously, by decompression and insertion of a chest tube. And in probably one of the most dangerous complications I've seen and often not spoke about is the importance of vascular access. And this patient, we'll see later, dropped hemoglobin over literally about 2 days at the swollen thigh. No one really could figure out what was going on with him, and it necessitated more. He had an abdominal ultrasound, which didn't show much. So we took this kid down to the scanner and found him with a large retroperitoneal hematoma, needed a laparotomy to diagnose the problem. It was actually from a vascular access attempt a few days before, and it was continuously bleeding. And in this patient, we actually had to withdraw ECMO for that reason, because we stopped heparin up to 48 hours, and the moment we restarted it, he started bleeding again. So we had to terminate ECMO on him. Fortunately, he survived, because when it happened, he was towards his ECMO run. ECMO was withdrawn in less than ideal circumstances. We had to do it onto an oscillator, but he recovered soon after that, and we were able to. The most important thing is we were able to stop the heparin, and he didn't need reloc laparotomies all the time. To emphasize that it's not impossible to take patients for imaging on ECMO. So this is a patient going down to the CT scanner. The most important thing is you need more hands and you need coordination. It's important for one person just to watch the pump only, and everyone else look after the patient. But practice becomes, that's the young man who I spoke to before. To talk to him in a few contexts. One was he had the big hematoma in the groin that extended to the retroperitoneum and needed a laparotomy. And the other thing was he became extremely resistant to sedation. And it was at a time when we were very busy, and I only got to see him about 10, 11 p.m. at night. And all the lights were off in the ICU, and all this guy was doing was looking around at everyone. So I had to bring him a lollipop and give it to him while we just went about and did our business. The picture on the left you can see is a veno-venous ECMO configuration. The oxygen line is clamped over there, and the oxygenator access and return is all the same color. That's because there's no longer oxygenation of that blood. You can see that patient is doing very well, trialed off successfully, and we're able to withdraw the wean and decannulate this patient. We look at the imaging because the lungs should clear at the same time. The blood gases should show the recovery of the lung in addition to the ECMO oxygenator, and the tidal volume should increase like I showed. Every now and again, as in this situation, we may have to come off ECMO in suboptimal conditions, be that as it may. There's often no choice in that situation. And of course, for futility, this is the spectrum of neurological complications that patients have incurred on ECMO, intracranial hemorrhages, extradurals, intraventricular bleeds. This is the entire ECMO registry of all the submitted CT scan abnormalities. Of course, the ECMO withdrawal is to redirect care. So the other question was, my patient needs ECMO, but it's too late. We can't do it here. But is it still possible? And the answer is yes. And this is something we've been concentrated a lot on because of patients that are being kept in the hope that they would get better, but then just don't. And if it's not too late and they do not have any absolute contraindications, consideration can be given to them being transported. So primary ECMO is when a patient is cannulated on site, stabilized, and then transferred, as opposed to secondary ECMO when you retrieve a patient already on ECMO to an ECMO center where they can be observed more closely. So that would be basically an algorithm. We have a very good sort of team with Netcare 911, through whom we do all our ECMO retrievals. Everyone goes through a learning curve with ECMO retrievals. The team from Karolinska in their first ECMO retrieval actually got commissioned a Hercules Army aircraft and simply drove the ambulance into the plane. There are other interesting pictures here because it was an Army issue aircraft. It needed an Army contingency. So there's what you see is this ambulance in the plane with a whole bunch of soldiers around it. And where we are now this is one of the longest ECMO runs done. It was from South America to South Korea. Subsequently, they've done 2 runs that were this long. Our longest run we've done is to retrieve a patient in Nairobi. Other than that, most of our runs have been local across into other provinces. This would be the information form that we use after the patient is accepted. So we basically do a telephonic discussion. It's a yes/no, referring clinician to complete this form more as a means of motivation for the service at a later date. This is our retrieval fixed wing service. We try not to use the helicopter at all. This patient, we take all the equipment with us, including the cannulas and the instruments. We do it at the bedside. The patient is set up for transfer, and we move them out. We notice there's definitely changes in flows according to altitude, but we make contingency plans for that. And once they're back on the ground, again, it's an ambulance ride to the hospital. This is a retrieval of a neonate. You can see there from Mpumalanga, Nelspruit. We actually did 2 in 2 weeks on this. And this a patient in an incubator, obviously, and we can see the setup in the plane, and that's what the X-ray looked like. Large right congenital diaphragmatic hernia with mediastinal shift, we did a vena arterial ECMO on him and on site, and then moved him across to Nelson Mandela Children's Hospital. Just a word of condolences. This is Dr. Nicholas Proctor. For those of you who don't know, we actually was of tremendous help. I've never seen pediatric ECMO, came out, and as you can see, he never left us until we took off in the plane. He was that interested in what we were doing. And unfortunately, after this event, I think 4 or 5 days later, he was unfortunately murdered.
Sorry, Krubin, we're going to run out of time soon.
Okay.
And there's so many questions for you.
Okay, I'm gonna stop.
Thank you. Do you have many slides? Are you finished?
These, Dr. Naidoo, these are just more sort of more interesting aspects of ECMO. So they are a few.
Maybe we'll just stop there and just
Sure.
the questions. Thank you for that excellent talk. This is also fascinating because so many of us are not exposed to this. My first question for you is that patients with meconium aspiration syndrome, many of them have PPHN, and we are forced to start cooling quite early. Now, would ECMO be possible in these patients who are on whole body cooling?
Yeah, absolutely. So I think, again, like I mentioned earlier, we don't get that many referrals for neonates. But the successes we've had have been, and the very short runs have been the meconium aspirations. And that's historically borne out as well. So you literally, if you need to cool, and as you're saying, you would put the heater cooler on because the circuit we use is compatible with the heat exchanger. It's very rapid cooling and very easy to turn it on, turn it up, turn it off.
Okay.
Systemic cooling. Yeah. We don't need topical. You don't need to do anything topically.
All right. Thanks for that. There's a question regarding outcomes in terms of survival and of the patients you've provided ECMO to, and then the long-term outcomes in terms of their neurological and cognitive function.
Yeah. So, again, so like I said, most of them, we don't do that many neonates because we just don't get referred any. And I think to date, this is our CDH group, literally, +1. So why I've put this on the left here is this kid went on to ECMO, and following the CDH repair had ischemic bowel, obviously demised. This kid had the CDH repair and then deteriorated from a pneumonia, went into ECMO, and then had vascular access problem and then exsanguinated. This is pretty much the only survivor we had who had a congenital diaphragmatic hernia repair. And this baby over here had successful ECMO retrieval, and then following the CDH repair, his liver expanded. I presume it was congestion because of venous obstruction, and needed about, I think, 3 relooks from his initial procedure, and the liver just got bigger and bigger each time, and that child demised. So neurologically, I've got in the neonatal group, I don't really have any information for you except this chap and this young lady here, because we've literally done only about 7 or 8 ECMOs. And the CDHs has been so the little guy I showed you earlier, Ignas. So in terms of survival of, if there is the question about survival of the neonatal group?
Yes, in the
Yes.
neonatal.
Yeah. So literally the only ones who survived the neonatal group have been the non-CDHs. I don't know what would have been like if they didn't have complications after the surgery. We had one child who had an uneventful CDH repair. He recovered, came off ECMO, and was fine. And the others all demised following the CDH repair because of the intra-abdominal component of their surgery. And then our other neonates are non-CDHs. So this young lady here was a congenital pneumonia. We had another child with meconium aspiration syndrome. And a third one, I can't remember exactly what they had, but those patients survived. Neurologically, she looks okay. The other little chap, I have a video on him. He seems okay. But like I said earlier, neurological outcome, everywhere in the world, if you look at all the papers, there are neurological consequences of ECMO. So it would be hard pressed to find it's just the degree of neurological insult that varies.
Okay, thanks for that, Krubin.
Sure.
Thanks, Krubin, for very informative talk. I'll just ask one of the questions in the QA, and then I'll ask my own question. The question is, do you get parental consent for ECMO?
Thanks. Yeah, so I really like that question, because when I presented this at Arabella, and I presented parental refusal as an indication for as a contraindication to ECMO, and it was Professor Bolton who said, if you feel strongly enough as the treating clinician that it's going to make a difference, you can override it. However, we have a very extensive counseling process. It takes at least 30 to 45 minutes with the parent, at least one parent. We prefer two, because almost all situations, it's a very traumatic moment. No one's really thinking straight. Everyone's distraught. The parents are often called to say, look, your child is busy dying and we have to do this, etc. So I think about 90% of our counseling is done in person. Very few are done over the phone. And what we find most often is that you have to redo it after the child is on ECMO. And it's not really about the benefit of it, but it's often about also the complications that can happen and what to expect going forward. So I can't even think of any patient who's not given consent after the counseling.
Thank you.
I don't know if that answers the question.
Thanks. And then I have a different question. Because of the risks that we know to the brain and the neurological function, do we do any neurological functioning during the ECMO? And also, do you image them routinely after the ECMO?
Yeah, thank you. So yes, so we do gross clinical examination. So that, because often the patients are very sedated. We do sort of mostly just pupils, and if there's a concern, because it comes back to the previous question, if it's a situation where the patient has been resuscitated, or there's questions about previous cardiac arrests and long time to return or spontaneous circulation, once the patient is on ECMO, we often try and withdraw the sedation and see, based on that history, if there's any signs of recovery or movement, etc. Whether there is or not, then we often go and image the patient, but the best we can do is a CT brain. For obvious reasons, we cannot do an MRI. We have the brains monitor that we may sometimes use more often as a sign of activity, or to look for subclinical seizures, so that we may add a anticonvulsant, because that may be preventing the patient from showing any signs of waking. But often we will add some kind of neurological monitoring onto the patient if there was an indication to do so, or we concerned that maybe the patient something has happened in terms of physical examination with maybe different pupils, etc. Or even with new onset seizures. Yeah.
Thank you.
Does that make sense?
Yes, yeah, that's what I was asking about. Yeah.
Krubin, I have an ethical question for you. You
Yeah.
know, if you consider the resource-constrained health sector and the limitation on ICU beds, can we really justify this expensive, costly procedure? Because, you know, my reading says it shows that it costs around 5,000 to even more, 10,000 US dollars to keep a patient on ECMO per day. So could we justify that?
Yeah, so it's a good question. So, you know, if in our setting, ECMO is mostly limited to the patients who are funded, and not patients in the sort of state sector, for predominantly the reason of cost, and also because often the patients have other criteria, maybe or other ICU acceptance criteria that may not be satisfied. But we, by and large, almost all the data you're seeing are patients who are funded on medical aids or privately funded, etc. That's the cost is something that's very difficult to justify in a resource constrained environments, sadly, but that unfortunately is the case. Yeah.
Mm-hmm.
I think if you are offering it to so we offer it post cardiac surgery to our cardiac surgery patients, because it's just, we feel it's justified because we've given them the option of the surgery. Pretty much the only group that will offer ECMO to central ECMO to on the state side, but not non-cardiac ECMO.
Okay, thank you. What is your experience with patients with BPD? Because we see a large number of our BPD patients being readmitted, especially during RSV season. And these babies will be, I think, a relative contraindication because many of them are small. Do you have any experience with these babies, these patients?
So yeah, I mean, it's very seldom that they'll come to us with that diagnosis. And often we go on what our referring doctors have told us. So what the patient's condition was like before surgery, or not before surgery, before ECMO, or before admission to the hospital. We've had quite a few kids who come into the hospital with the diagnosis of BPD and have any other procedure done and then deteriorate with the same condition as a child without BPD. So we use that as I wouldn't say justification, as encouragement to say what was the condition of the child before, and the best we can do is try and get them back to baseline. The size of the patient doesn't really affect us that much. I would say the underlying lung condition, or the underlying pre-morbid clinical condition of the patient. Now, I wouldn't say that's a foolproof situation. We have had a child, not a neonate, where we were given the wrong information. And we put the patient on ECMO, and then only to find that the patient got recovered, but got to a point where they were not showing any further recovery, beautiful X-ray, etc. But we couldn't get any further, and only to realize from another family member that the child was not well. And that patient we had to actually withdraw because it was clear we were not going to get any improvement to allow a further recovery. But certainly we go on the referring, and often we have a pediatrician, like sort of the house pediatrician of the patient, who will also give us some information about the pre-morbid state of that condition, before we would actually get to the point of doing the case. But we've not. I can't remember us refusing a case because of severe bronchopulmonary dysplasia.
All right. And I know you showed the renal replacement apparatus that
Yes.
you use during the procedure. Do many of these patients go into chronic renal failure subsequent to the ECMO intervention? Would they follow through to chronic renal failure in later life or in their pediatric years?
So in terms of the neonates, I've showed you all the ones that we've done have not needed any chronic renal replacement therapy. If you're asking about the older kids, I can't recall. So we have had situations where we've taken patients on ECMO and then replaced the ECMO circuit with the dialysis circuit. I don't actually even know. I won't be able to tell you that number if anyone is in chronic renal failure, but from our interaction with our renal team, who we work quite closely with, there's no mention of anyone who's actually on chronic renal. You see, I think one of the theories is the absence of pulsatile flow when patients are on ECMO is a sort of a trigger for oliguria, and it returns once they return, once the kidney is exposed to pulsatile flow. So our ECMO machine has a pulsatile mode that's set on as a default. I'm not sure. I'm not convinced about that label and that pulsatility.
Is that for both veno-arterial and for veno-venous?
Yeah, so veno-venous patients have continuous pulsatile flow, right? Because it's all the left side of the heart still ejects from the left ventricle. If the left ventricle is still pumping towards the circulation. For veno-arterial, you've got ECMO flow being returned into the arterial system, so that may override the pulsatility of the ventricle. So literally only for veno-arterial will you be looking at what's the word? Attenuation of pulsatile flow. But veno-venous, not at all, because the ventricle will still be. Remember, what you take out the right side, you replace, but you just replace it with oxygenated blood. So the left ventricle is still pumping. There's still pulsatile flow to the kidneys.
Right.
On veno-venous, right?
Okay.
Let me find that.
Yes.
Krubin, can I ask another question? Do you sometimes have patients that you need to repeat the ECMO, and can you predict that?
Yeah, thank you. So not. I literally think it's not happened until very recently, and I'm not sure. This year we had 2 patients who subsequently deteriorated. So we follow a strict weaning protocol. Sometimes more than once to see if the patient can tolerate. So veno-venous ECMO is very simple. Veno-venous ECMO, you simply disconnect the oxygenator, and essentially the blood being removed from the patient is what's being returned as venous blood. And if they cope, then they'll come off ECMO. If they don't cope with that, we just reconnect the oxygen. Veno-arterial is a bit trickier. And obviously neonates are the most tricky because you can't reduce the flow of the circuit that much. Otherwise, it will just start clotting off. So veno-arterial, you literally have to reduce the flow. I reduce it to about 25% of the expected flow. Give them about 15-20 minutes, and then do a blood gas and look at the oxygenation, carbon dioxide removal, and lactate production, as well as their hemodynamics, so the blood pressure and capillary perfusion. while we are ventilating them at minimal ventilatory settings. If it's an acceptable gas, then we will proceed on to decannulation. And that's worked all the time, I can say, literally for years and years, except this year. And this year we had one child who deteriorated after like 6 hours. We had to come back in and emergently put the kid back onto ECMO. And another child we had after 2 weeks who deteriorated, and we had to go back in and put him on ECMO. So sorry, 3 this year. The last 2 were actually burns patients, and those burns patients were a long way from actually discharge. So they may have picked up something nosocomial, but there are no. The reason for reinstitution of ECMO would not be. It wouldn't be predicted. Let's put it that way. It'll be on the same parameters that we would need to. That we would put them on ECMO in the first place. Now, having said that, I've also had a child who returned for ECMO a year later. And obviously, that was a surprise. And that's obviously got nothing to do with the underlying lung, because she was actually well. She just seemed to get adenovirus and respond very badly to it. And then we had to adopt a different cannulation strategy. I have also put on a patient who had ECMO at another hospital 2 years prior to coming to us. And that patient was a severe anaphylaxis, and we think it was the same reason he went on to ECMO the first time. But yeah, there's no real predictors of recannulation when you decannulate the first time. And I'm always of the opinion that if it's a very marginal reason, unless you're absolutely obligated to take off ECMO, I will rather leave on ECMO for a little while longer. And usually every 48 hours, we'll evaluate. So once the lung shows signs of recovery, the X-ray looks good, and we get it. When I say recovery, we're looking at least tidal volumes of 6 moles per kilo at a maximum inspiratory pressure of 20, then we will consider taking them off. If they haven't reached that level, we don't even try and wean unless they reach 6 moles per kilo at those airway pressures.
Okay, thanks very much.
Thanks, Krubin. I think I'm going to close the meeting now. There's a few more questions, and we'll send out the recording of your talk to all the attendees. I want to thank you for joining us this evening and for this excellent talk, and also for all the hard work you do. And thank you for making ECMO a little more accessible in Africa. And we look forward to hosting you at another time to see what the latest is with the mobile and retrieval services. Thank you so much, Krubin. And
thank you very much.
All the attendees who joined us, thanks for your time and participation in the questions and answer session. And we look forward to seeing you in the Drakensberg in 2 weeks. Have a good evening, everyone. Thank you.
Thank you, Krubin.
Bye.
Thank you, everyone.
Thank you.
Bye.